Contrast can be explained to the patient in a very simple basic words. I'll go something like that. Contrast is like a glow in the dark. We put material in your body that goes to any abnormal area and highlights it for us. It's crucial for diagnosis and the right treatment. Also, I will mention to the patient, besides the benefits, the risks of the contrast. Again, I will explain it in the most basic, simple words. I would say that there is risks of allergic reactions and very rare kidney disease. But our department is well prepared to come to aid if something like that happens. Plus, I'm here, I'm watching, and I will come and help immediately. There are major concerns and or complications connected to IV contrast administration. Those are NSF, severe allergic reactions, and IV connected complications. So NSF is nephrogenic systemic fibrosis. This is very dangerous, incurable, progressive, and debilitating disease. Patients with impaired kidney functions whose GFR are less than 30 are more likely susceptible to for this to occur. This is rare, and also patients with known liver diseases are also susceptible to that. As for severe allergic reactions, patients with asthma or respiratory allergic reactions are known to be more susceptible to this occurrence. It is also rare, but if it happens, it's an acute medical emergency. As for IV administration, there are problems like infiltration, ebullience, and infection. There are steps in the department we can take to eliminate or minimize those major concerns. First of all, we know that the filtration rate, GFR, is supposed to be over 30. If it's not, we do not administer the contrast. If also the date of the test for filtration rate is over 30 days, again, we don't do the contrast. Most likely, we just send the patient to take the test again and bring us more recent results. Another thing is that we can precisely calculate the dosage, so we don't have any problems injecting too much gadolinium. For that, we take the recent patient's weight, divided it by 2.2 to convert it into kilograms, and multiply it by 0.2 milligrams per kilogram. That's how we find out the dosage. However, if the patient is overweight, 300 pounds, 400 pounds, we'll get the number more than that. We will never administer more than 20 to the patient, even if he is oversized patient. Also, the gadolinium for pituitary, let's say adenoma, we do not administer all 100% of the value we got when we calculated it, because then the image will be overwhelmed, like very bright. So for pituitary, we would do half of the dosage we get. And another great protocol we have for the patients who actually had a severe allergic reactions in previous MRI with contrast exams. For those patients, we have a so-called pre-medication protocol, and for that, the doctor just prescribes necessary medication to the patient. Patient goes to the pharmacy, gets the medication, and it gets administered before the MRI exam. This way we protect the patient, and also we get great images. Complications connected to IV are infections, air embolus, and infiltration. Infections are very preventable things. We can start by washing our hands thoroughly. I would do it about 20 seconds or more to be on the safe side. Then all the IV syringes and lines has to be taken out of the sealed packs. We should never use the open packages. We have to throw them out. So we make sure everything is sterile and we can proceed. We have to wear gloves at this point, and also to clean the skin with alcohol or some approved cleaner at this point. UV hubs have to be scrubbed with alcohol pads prior using them. Injections have to be done only in vein. That's why it's called IV, intravenous. It is no to inject into the artery or into the tissue next to vein. If we inject it into the artery and we pull the needle out, we'll know what happened, because the blood will be pumping out very badly. And as for injecting in the tissue, we will cause infiltration that actually will cause the swelling of the tissue, and also we'll see even some sort of like leakage, looking like a sweat coming out of the skin. It is painful, and it is unprofessional, also unacceptable. Air embolus is a very dangerous thing to do. It is injecting the air inside the patient. This is unacceptable because it is very dangerous. It can be fatal. Our human body is capable of dealing with the tiny pieces of tiny particles of air, but we know that tubing in MRI can be very, very long, and without realizing by mistake, it is possible to start injection, and all this air is going to go into patient. This is really fatal. So to avoid that, at all times we have to make sure we push the air out by pushing the fluid in and making sure the drop is coming out out of the other side, the drop of the fluid. There's an air embolism in the organ. We see it's the dark color. That means it's an air and it doesn't belong there. This is air embolism. Also, power injectors. They have two tubes. One is for saline and another one for injection fluid. Both of them have to be in order. So there should be no air in the injection tube. Again, we have to push the air out by pushing it out with the fluid and make sure that the drop coming out of the opposite side. There is one more concern is worth mentioning. When we do pre-contrast imaging and post-contrast imaging, we have to walk in the room after the series of pre-contrast imaging, and the patient intuitively would turn and move. So at this point, we have to, in advance, tell the patient, explain the patient what's going to happen, and make it clear to the patient that the patient should not move when we walk in the door between the scans and inject him or her with contrast. There are ways the MRI department prepared or addresses the contrast agent complications. Allergic reactions, those are rare, but it is very important to act very fast. First of all, we have to remove the patient out of zone 4, out of scan room, at least to the zone 3. But first of all, once we injected the patient, we have to watch for signs of allergic reaction. For every difficulty of breathing, rashes, hives, drop in blood pressure. As soon as we notice the patient has hard time breathing, we have to call the code. Then we remove the patient from the scan room, zone 4, and at this point the radiologist or nurse should be dealing with the patient. Also, there is a crash cart in the hospital, in the MRI department. Usually it actually even in the zone 1, but it is always available. There is also a small box of medications that are in MRI department close by. It contains, among everything else, epinephrine. So at this point, doctors and nurses, then they can use these medications on hand. Afterwards, the report has to be filed. But things happen. Sometimes patients refuse contrast. What I would do, I would just record that, and most facilities allow the study be performed without a contrast as a more limited study. Patient is welcome to come back if it's needed.